I know everybody likes to talk about delivery, but I'm going to save that until the end. I'm going to kind of start at the first trimester. So in the first trimester, emergencies that can happen and that come to mind first for me are ectopic pregnancies. Actually, one of the leading causes of maternal deaths worldwide are ectopic pregnancies. So you may get a call for heavy vaginal bleeding, maybe someone just with syncope, maybe they're just like totally out of it and they call EMS because that's how sometimes ectopics present. Their vaginal bleeding sometimes is not very impressive. You're going to be like, oh, you called us for this isn't anything. But they're losing a massive amount of blood in their abdomen. So really in all of these pregnancy emergencies we're going through, the big thing is blood loss, just difference of where is it coming from and how detrimental is it to mom and baby depending on how far along in the pregnancy. So in the first trimester, it's clearly just a maternal issue and ectopic pregnancies with the intra-abdominal blood loss. So they will have significant pain. Their abdomen will be super tender. They will have rebound. They will have guarding, but the vaginal bleeding may not be so much. IV fluids are going to be the best thing you can do for an ectopic pregnancy en route to the hospital because with that blood loss that you can't really quantify because it's all internal, their vitals will start showing signs. First, they're going to become pretty tachycardic, then they're going to get hypotensive. By the time they're hypotensive, they're pretty sick. The nice thing about OB is most of our patients are pretty young and healthy and can actually handle a decent amount of blood loss before they decompensate. So that is ectopic pregnancy, first trimester. Trying to get an idea of how far along people are in their pregnancy is really important too. You'd be amazed the number of people that can't tell you when their last period was, when their due date was. If they've had an ultrasound recently, they can't tell you. So ways we can estimate how far along the pregnancy is if the patient can't tell us or is unable to tell us. So we use what's called fundal heights. So when you feel on their abdomen, if you can feel the uterus at their belly button, they're 20 weeks, roughly. And then for every centimeter above the belly button, you add a week. So at 25 weeks, you're about 5 centimeters above the belly button. If they're up to their rib cage, they're probably close to 40 weeks. So that's an important thing to do if the patient's unable to tell you so that you can relay that information to the team at the hospital. Because that changes how we manage it, knowing is this a viable pregnancy, meaning 24-ish weeks, or is it a lot less? So then we can kind of move on. Well, first trimester too, you're going to see miscarriages and bleeding from pregnancy losses. Those people are going to have pretty significant vaginal bleeding that you're able to quantify and know what's going on. Same rules apply. We need IV access. We need fluids going to maintain mom's vitals until she can get to the hospital. Second trimester and third trimester, we can kind of group those emergencies together. So the textbook answer is the vaginal bleeding with or without pain? So vaginal bleeding, second, third trimester without pain, we think of a placenta previa. These are pretty uncommon, but it's where the placenta is implanted and part of it or all of it is laying over the opening to the cervix. These typically present, like I said, with no pain. They will have just sudden onset of random bright red bleeding. These can be dangerous to both mom and baby. Obviously, the blood loss is coming from mom, but that blood loss is then not getting perfused to the baby. So IV access, fluids, maintaining vitals. These patients don't usually decompensate quickly from a maternal standpoint, but the babies can look pretty bad. And then the other type of bleeding, second, third trimester, is a placental abruption. So these are more scary to us. The placental abruption can happen, so it's where the placenta separates from the wall of the uterus. And that bleeding can kind of accumulate in a pocket between the wall and the uterus before it finds a way out and we start seeing the vaginal bleeding. So most of the time, by the time they start having bleeding that we can see, they've already lost a lot more blood within the uterus. And usually by that time, baby has already passed. But moms can get really sick. They most commonly go into DIC. It's a whole thing. They don't leave the hospital for a while. Same rules apply there. Get an IV, get fluids going. Hopefully when they get there, we have lots of blood products ready for whatever hospital you're going to. Another OB emergency, so seizures in pregnancy. They could be just a regular seizure disorder that someone has before they became pregnant, and that's why they're seizing. But in the second and third trimester pregnancies, when a pregnant woman has a seizure, we need to think about preeclampsia. Preeclampsia is associated with high blood pressure first, and then it develops into eclampsia, which is that seizure due to the blood pressures. IV access is, again, important. We treat these with magnesium rather than benzos, like regular seizures are usually treated with. And moms can actually die from this. It's also one of the leading causes of maternal death because moms can have brain bleeds during these seizures because their blood pressures are so high. I guess what do you all have like with you to treat blood pressures, if anything?
We carry magnesium and labetalol.
Oh, fantastic. Do you know what dose of magnesium you have?
I think our protocol is like 4 grams over 5 or 10 minutes for eclampsia.
Okay, great. So yes, that 4 grams of magnesium IV is exactly what we would give. If the mom is already seizing, don't even bother putting in an IV first. Give it IM in the butt. So give 4 in each cheek, and then worry about getting your IV access and getting some labetalol. And we usually, if somebody's already seizing, I'm pushing like 80 of labetalol. You could do 20 at a time if you wanted to, but it's not going to bring your blood pressures down enough. But having that magnesium is super important. And even if like the family's like, oh, she has a seizure disorder, that's probably why she's seizing, give the mag. It's pretty harmless. I mean, they're going to feel kind of crappy from it, but from a risk standpoint, it's better to just give the mag. It's not going to have any, bad effects to mom or baby just to give it. And then we can go to delivery. So the good news is most babies that are coming quickly at home are going to come whether there's someone there to catch it or not. Those are usually the pretty easy deliveries. So it's a lot of chaos when someone doesn't have anesthesia for a delivery. If you can just lay mom's back, get their legs abducted and flexed up, I think of it like putting their knees towards their shoulders and getting them to bear down. Obviously, with you all, if mom doesn't need to push, don't encourage her to push. Just wait until she gets to the hospital. The head will come when it's ready to come. The emergency comes when the shoulders don't want to come, and that's called a shoulder dystocia. There are specific maneuvers we do to get the shoulders out. So the first one is called McRoberts. So that's positioning of the legs, like what I talked about. You want to get those legs flexed way up and way out to the sides and have mom push on her own. What you're doing as the delivering provider in that scenario is you have a hand both on the top side of the head and the bottom side of the head, and you are pulling at a downward angle gently. People always worry about hurting the baby on the way out, but broken bones, broken collarbone, broken humerus on the way out will heal just fine. Its brain being deprived of oxygen won't heal just fine. So use a little force if you feel like you need to, if that's what it's going to take to get the baby out. So downward pressure with maternal effort. We call that the McRoberts maneuver. That's the first thing everybody goes to get the shoulders out. If that doesn't work, the next maneuver is suprapubic pressure. So you want mom laid all the way flat, legs still positioned in McRoberts, and someone is going to push right above mom's pubic bone, and you're pushing down and slightly to the side in the direction of where baby's face is looking. I wish we were in person and we had like the dolls, because it makes a lot more sense when you actually see it. But if you just picture baby laying top to bottom with one shoulder up and that shoulder is stuck behind mom's pubic bone, you want to decrease the diameter of baby's shoulders by pushing downwards, and then you want that shoulder to slide anteriorly towards baby's face to slide under the pubic bone. And then once that's delivered, you can just pull the baby out. It may still be a tight fit, but the bony parts are through, so no worries there. What you don't want to do if a placenta is coming, or if you're delivering a placenta intentionally, is you don't want to put your hand at the top of that uterus and push downwards towards the vagina. Because what can happen is you can cause a uterine inversion. So you can flip the uterus inside out. And that's a different type of OB emergency I hadn't even thought of until we got talking. So best to just do like a circular belly massage, maybe nothing. It may deliver on its own, and that's fine. So if you get there maybe after a delivery, and mom is having significant bleeding. So the baby's out, the placenta's out, she had her happy home birth that she wanted or whatever. Uterine massage is going to help the uterus contract down. So atony, or the uterus being, we call it boggy, or it's just not wanting to contract, is the leading cause of postpartum hemorrhage. And that can be resolved often by just doing significant fundal massage. And it hurts, and you're going to feel like a jerk doing it, but it really does help with the amount of bleeding that mom will be losing. And that postpartum hemorrhages don't necessarily happen like in the first hours postpartum. So there's primary and secondary hemorrhage. So primary hemorrhage is that hemorrhage that happens within 24 hours of birth. That can be caused most commonly from atony, but we also think about laceration. So especially people that have had home births, they've not had anyone, check for tears after delivery. It could be a laceration and not so much from their uterus. Lacerations can happen both like external, so like perineal lacerations that we think of commonly with delivery, but also cervical lacerations. So in people that are maybe having a home birth and they're just, listening to their body on when to push, they can tear through their cervix. So if they start pushing before the cervix is fully dilated, that cervix can tear and they can bleed a lot. So yeah, I think that's what I've got. Do you guys have any questions at all, or anything you want me to go into more detail about?
Postpartum hemorrhage, it can also occur after they get home from the hospital, correct? Or
for sure. Yep.
I'm also thinking of eclampsia. Eclampsia can also occur then too, right?
Yeah, so eclampsia we think of for 12 weeks postpartum. The farther postpartum they get, the less likely it is, but I've definitely seen it at 5-6 weeks postpartum. I don't see it at 12, but it can definitely still happen. So yeah, like I was saying, as far as like giving the magnesium during pregnancy, if they're recently postpartum, give it. It's not going to hurt anything. And same with hemorrhage. Yes, hemorrhage can be delayed for weeks. Now, after that 6-week mark, it's kind of hard to know, like, is this some kind of weird retained placenta or something causing a hemorrhage, or is it just a really bad first period since baby? Because that can happen too.
And so we don't carry oxytocin, but if fundal massage doesn't work, do you ever give TXA for severe postpartum hemorrhage?
Oh, absolutely. TXA is good stuff. So yeah, give that for postpartum hemorrhage, and honestly, give it to your pregnant moms. So we give it, like if I'm doing a C-section on someone who is a high risk of bleeding, like they've been on blood thinners, or maybe they've had 5 C-sections and we know their abdomen's a mess, we give TXA before we do the C-section. So if mom is bleeding even during pregnancy, TXA is fantastic. The only time we probably shouldn't give it would be like in our hypertensives, but usually they're there for high blood pressure, not for bleeding. But if their blood pressure is significantly elevated, you don't want to give TXA because of the clot